Good morning, everyone. Happy Friday. All right, we made it. Well, first of all, my name is Joe Zapata, and I work with the University of Texas Health Science Center, the South Texas Geriatric Education Center, and along with the VA and the GREC located here at the Audie L. Murphy Memorial Hospital. We would love to present to you the final day of the Summer Student Aging of 2013. Before I get to the other important things concerning this conference, I'd like to present this week's conference in memory of Dr. Patrick Linder. He was a physician who worked here at the VA and was cross-appointed with the UT system, who was tragically and unnecessarily killed by a freak accident that occurred this past Monday. He was survived by his wife, who's also a physician, and his 2 young children. We will keep him in his memory, and it was such a abrupt and unfortunate occurrence that it could have easily happened to any of us. If you walk down the street in the medical center, it could have been you. So I'd like for you to just be careful as you walk across the parking lots today and across the street. It's a very dangerous intersection with a lot of people rushing. So just take the time and just be careful, and just you know, this conference is about aging, and let's be fortunate enough to actually get up to that point where we're actually aging, you know, and not die so young. He was 33 years old, which is he had many more years ahead of him. So let's just keep that in mind. Okay. Another thing, I'd like to thank our committee members and all those who helped bring this conference together. Mark Johnson, or the doctor right here. Barbara Giles, or there you go. Geriatric, who's helping me in the back with the system and helping me out. Chris Carr. Let's see who else. Sony Samples, Sui, who's Unzelman, who is viewing from Kerrville right now. Give a shout out to Sue. Robert Novak, Dr. Lucy, Barbara Waltz, Elizabeth Packer, Mary Farmer, who has helped us gather the continuing education credits, Dr. Royal, and last but not least, Tressa Brock, who has been running around up and downstairs helping us out in every task way. So just thank you so much, Tressa, for all your help. Okay, now to the paperwork real quick. Make sure that you have filled out the person profile, front and back, just once. All we need is just once for the entire week. And if you liked what you've seen or you missed an aspect of this whole week's conference, be sure to fill out the order form for the DVD, the CD. You can order either or for any day this week, or you can order for the whole week. Make sure that you fill out your, if you're non-BA, your non-BA registration request and your evaluations. And if you are BA, be sure to go on to TMS and fill out your online evaluations as soon as possible so you can receive all the credits that you are that are due to you. Without further ado, I'll to introduce the first presenter, which is Sandra Fox, who will be talking about the aging eye. Thank you.
We'll do our best. I was thinking about it this morning. You know, the older I get, the less fun these talks are. Because as I talk about it, I'm like, oh dang, I'm starting to notice that. It was more fun to talk about the aging eye when I was, like 30. This is not as much fun. So one of the things we're going to talk about this morning is what's normal and what's not normal. And I think that we all know that one of the things I was talking about with a good friend is when you have little aches and pains and things that happen when you're younger, you don't even worry about it. You just blow it off. You get to be this age and it's like, well, is that something I should be concerned about? should I go to the doctor for that? And, you know, we were saying how much we hate that, because it is hard to know what is normal and what is not normal. And so that's what we're going to talk a little bit about this morning. And this is just a nice, you know, everybody's seen a picture like this about the eyeball. And so it kind of makes sense that when you have an eye, anything that can go wrong in any one of these areas can cause a problem with vision. The eye has a lot of different clear areas, so that light has to get through a clear cornea. It has to get through the aqueous. It has to get through a clear vitreous. Then it has to get to the back of the eye and the retina. And we better not have any diseases back there, or we're going to have a problem. Then it's got to go to the optic nerve, and again, we have a lot of things that can affect the optic nerve. And this is a shorter talk, but if we go even further back and we trace the optic nerve, the wrong way, all the way back into the brain, you can have all kinds of stuff go wrong back there, especially as we get a little bit older. So frankly, you know, as we get older, it's a wonder we see it all when you think of all the things that can go wrong. So some of these, first we're going to talk about some of the normal changes that can occur in the eye. Visual acuity, accommodation, that's the ability to focus up close, our peripheral vision, our visual fields, light sensitivity and glare, contrast sensitivity, dark adaptation, color sensitivity, and dry eye. These are all things that can happen as we get a little bit older, and I'll talk about each one in a little bit more detail. So visual acuity is just talking about what size object can you see. And so that's what we normally think of when we think of vision. We think of 20/20, 20/30, 20/40. What is it that a person can see? That starts to change around the age of 50 as we tend to become a little bit more farsighted. So people that never had to wear glasses at all will start to need to wear glasses when they get to be a little bit older. They'll start noticing difficulty seeing up close, and then eventually they may need to have glasses for distance as well. The other thing that happens is we have some subtle neurological changes that occur in the brain that can cause us to have a little bit more difficulty with fast-moving objects. A drastic decrease in visual acuity is not a normal aging change, and that's the most important thing, is that I think that a lot of times patients won't go in for an eye exam because they just assume, well, this is just what happens. You know, you get older and you just can't see. And yes, eye diseases are more prevalent as we get older, but it's not necessarily that it's going to drastically change to where you can't read the newspaper or you can't drive. Accommodation is the ability of the eye to be able to focus up close. And when we're younger, we can do that very, very well. So that even children that have 2200 vision can do very well in school, because young people can use focusing mechanism inside their eye and just hold things closer and do very well. Right around the age of 35, 40, we start to lose that ability to focus up close. And then when that happens is when people start realizing their arms are not long enough, and they go to the dime store and, you know, get dime store. Didn't I just really show my age?
Yeah.
Does everybody here even know what the dime store is? That's one of those things, if you said it to a younger crowd, they go, dime store? What's a dime store? I mean, even the dollar store is not really the dollar store anymore. So this does start to happen. We get a little bit, you can just pick up the over-the-counter reading glasses, which is what a lot of people do. And the reason we do not like people to just go pick up the over-the-counter reading glasses is because a lot of the other eye diseases are more prevalent over the age of 40, like glaucoma, cataracts. And so if somebody could just pick up a pair of glasses over the counter, they may not go in to get an eye exam. Now, I often will tell people to go pick up the over-the-counter reading glasses. But the over-the-counter reading glasses have the same prescription in both eyes. They don't correct for astigmatism. And so frankly, most people, they're not going to be the best pair of glasses for them, because it's rare that you have exactly the same prescription in both eyes. And it's rare that you don't have any astigmatism at all. So really, those glasses are not going to work for most people. But the big problem is that it keeps people from going in to get an eye exam. We also can, you know, if somebody comes in and we find that they can wear the over-the-counter reading glasses, then certainly we're going to tell them just go pick these up rather than spend a lot of money on a pair of glasses. So this is a really easy thing to fix. We can fix it by using reading glasses or going into bifocals. One of the things that I wanted to throw out is a lot of people will resist getting reading glasses because they think that if they get them, it makes their eyes get worse. And it's not true. You're never going to get worse whether you wear them or not. It's just an aging thing. But what will happen is you get used to seeing well, and so you don't like to be without them. And so that's one of the things I have to clarify with patients. The visual field refers to our peripheral vision, or we can have a central field as well. So the size of the normal visual field decreases by 1 to 3 degrees per decade, so that people in their 70s and 80s may have a total visual field loss of 20 to 30 degrees. Now, this is really important for driving, because what really saves our life and the lives of others, we heard the talk earlier about driving, is peripheral vision. You know, that's where you catch that car that's darting across traffic, or you know, you catch out of the corner of your eye a kid running after a ball. That is important, is peripheral vision. And so that may be why our older drivers may not be quite as good, because you know, right now, you know, I can kind of see this hand over here and this hand over here. 20 to 30 degrees is about like this, and that's a pretty substantial difference. Then you add in that the neurological changes that occur in the brain, where you don't see fast-moving things as quickly. You know, that can be a risk for driving. So that's one of the things that we have to keep in mind. Having said that, in the state of Texas, there is no visual field requirement. So somebody with retinitis pigmentosa that has 10-degree fields, but 20/20 central vision, can still get a driver's license. And I can tell you that that person should not be on the road. And so that's kind of an interesting little Texanism. Light sensitivity or glare is caused by opacities in the lens and vitreous that increase the scattering of light. Cataracts can really increase glare. And then when they're removed, now you're very light sensitive, because the cataract is just, as it changes slowly over time, the lens inside the eye slowly over time becomes a little bit more opaque. And so that does reduce the amount of light that gets into your eye over time. So that when people have cataract surgery, suddenly the colors look brighter and everything looks great, and they love that part about it, but the South Texas sun can be a little bit too much. So sunglasses are very helpful with glare and with light sensitivity.
What do you think about transitions?
The transitions are good. The problem with the transitions is they work better the colder it is outside. So in Texas, they don't get nearly as dark as they do in other parts of the country where it's not as hot. So the transitions are good, but for most of our patients, they're actually going to need what we call fit-overs. And the fit-overs are really nice because they protect from glare on the sides and they protect from glare on the top. A couple of years ago, I love to hike, and a couple of years ago I was hiking, and it was kind of, the sun was getting low in the sky, and I was really having a hard time seeing the rocky terrain. And I went like this, and what a difference it made. And I thought, oh no, here I am. You know, I'm now on one of those patients of mine that needs to get the fit-overs. Well, I'm not going to get the fit-overs just yet. But you know, unless I forget my regular sunglasses. You know, if you see me driving down the road with those stupid mid-Adriatic specs on, it's because I forgot my sunglasses that day. But, you know, it really did make a huge difference. And so even though, and I had a patient the other day that was in her 40s and asked about a cataract, and the truth was, she did have some lens changes in her eyes. But I don't really like to call it a cataract until it's really affecting vision. And so all of us, you know, as we get older, the lens is going to change, and you're going to start noticing some difficulties with glare, night driving, and things like that. So the transitions are great, but here, if you're light sensitive, they're not going to get dark enough. You're going to need something else. The other thing that we do is contrast sensitivity. That's the other thing that goes with glare. And contrast sensitivity is the ability to recognize detail even when the detail is very faint. Like the lighter ink they're using in the newspaper. And this really decreases with age. And it's thought that it's due to a decrease in something that the processing that occurs in the brain. And certainly before you have cataract surgery, it's happening because the lens is changing inside the eye. Yellow tinted lenses, those shooter or driving glasses can help. And then good lighting is really, really important. Oops, I don't have a slide of it. I use a contrast sensitivity chart that has very, very dark print. All the print is the same size, but it gets a little bit fainter as you go down. And I have the patient read as far down as they can. I really glare it out with a lot of lights, and then we have a lot of different tints. Yellow, orange, amber, green, gray, blue, red, all these different colors, and I flip them until the patient can read a little further down on the chart. And the color changes depending on the disease process that they have going on in their eyes, their age, just a lot of different things, even personal preference. For instance, people with macular degeneration tend to do a little bit better with amber. Patients that have diabetic eye disease tend to do a little bit better with green. Yeah, that's another interesting thing, is it's really easy to find amber and gray sunglasses. Green used to be very popular. I remember when we were kids, my dad always had a pair of green flip-ups that he wore all the time. A lot of people do better with green. And so I think that it's hard for our patients to find green. We can get green made, we can get any color made. And we have a great optical that we use that when we find the tint that they need, we can just get exactly the color that they need. And so what we will do is just really customize the tint that's going to work best for that patient. And it's a really easy test to do, and it makes a world of difference. Lighting, Ms. Andrews is going to talk, yes?
Are there any colors you should avoid that have down in the vision?
Not really, unless it's, and I should say, for some people, yes. For some people, certain colors are going to be horrendous for them, and then other people, certain colors are going to be better. But to just tell somebody, no, this color is bad, I can't really say that. To each individual, that may very well be. For instance, the yellow tint works great for some people, but for other people, it's just too bright. Other thing is, and this is fairly new in the literature, it's that some tints seem to work better for migraines. And so the blue colors, the purple colors, they're finding that for some people that really helps with migraines. Well, that would make sense then, that if a bluish color works well for you with your migraines, then a yellow would probably be really bad because it would be too bright. I haven't really had a chance, yes?
What about backlit things? You know, more and more now everybody's got tablets or phones or computers.
I think that's a good question. And patients need to vary that. I mean, they need to work with that and find what works best for them. For me, I love it.
Yeah.
You know, I read on my iPad, and I really love it because you know, at nighttime I don't have to have good lighting. You know, I can just sit in bed with the lights off and read with my iPad. You know, usually I'd be reading and I have this nice little lamp next to my bed, and I'm all under the lamp as much as I can get to get the lighting that I need for reading. So I think that's one of the reasons people really like those devices, is you're not as dependent on external light. One of the docs that I visit, I love her office. It's so, gosh, relaxing. But the lighting is so dark, you can't even read her magazines. I mean, it's really dark. She has one window, and I'll get over there by the blind, open them up, you know. And so now I just take my iPad, I can read anything I want to read. So I think that's why they're very, very popular. Dark adaptation is the ability of the eyes to adjust to changes in light levels. So when you're going from outside to inside or vice versa. And as we age, that adaptation takes a lot more time. And it's mostly due to changes in our iris muscle and the pupil size. So it just doesn't make that change where it constricts when you go outside and opens up quickly when you go inside. It just takes a little bit longer. The ambient light needed for reading by people in their 60s is 3 times that needed by people in their 20s. And boy, I have really noticed that. Like I said, I used to be able to read anywhere. And now, if I don't have good light, I just have a harder time. Again, the transition lenses are good for that, because as you go in and out, they change. So that's nice. And then the fit-overs are great, because you can just take them off the minute you walk inside or put them on the minute you go outside. I don't know, some people have, I've always had poor light-dark adaptation ever since I can remember. If I go into a movie theater, I mean, I'm standing there for a minute before I start walking down. And so that also is going to be different from person to person. So I know for me that it's just always been that way. But as people get older, if they were able to do that quickly, they're going to notice a change. And that's a normal thing. So the ability to distinguish colors is contrast sensitivity, and this declines with aging as well. We only have 3 cone cells, the blue, green, and red, and they're responsible for all color vision, so that all 3 of those decline in sensitivity. So colors are less bright, and contrast between colors are less noticeable. And the way, I mean, it's not like you're not going to be able to tell red from green, but you think about those paint chips. You know, when you go to the store and you're trying to figure out what color you want, and they've got those gazillion colors that look very close, that's where you start having a little bit more trouble. But interestingly enough, I will have patients that will be vision impaired, and we have this great color test that they look like eyeshadows. You know, all these are poker chips depending on your gender. Well, not always, but you know, most people will follow in that department. So each one is a little bit less shade. And yet I'll have people with 2200 vision and still do very well on that test, even my patients in their 90s. So when we talk about this color sensitivity, it's a generalization. And I just see that most patients still do very, very, very well. Cataracts affect color vision. Macular degeneration affects color vision. I do color testing. I used to do it on every patient, but it is a fairly time-consuming test. And so I tend now to reserve it for my patients where color is really important to them for their job or their hobby. And even if they have reduced color vision and the person is an artist, you know what I tell them is, you know, art is how you perceive the world. So it doesn't matter if you have color vision deficit. It's just that is how you see the world, and that is what your art is going to be like. And I think that people need to realize, if you look at the masters, their art changed over time because they didn't have cataract surgery back then. So their colors became more muted, and frankly, I love the ones that did their best work to me, like Monet, after his cataracts developed, because I love those soft colors. In fact, when I was a kid, I have a lot of astigmatism, so without my glasses or my contacts, everything kind of has a halo around it. I would take my contacts out to go look at Christmas lights, because they just look so much prettier, I thought, without my contacts. Now that gives you an idea of what an oddball you have that's up in front of you talking on a Friday morning. So tear production does decrease with aging, so there are fewer tears, and so the eyes do dry out. And you know, that makes sense. You know, our hair gets drier, our skin gets drier, everything just gets drier. Well, we do have a lot of artificial tears, and we even now have prescription drops. So there's no need to suffer with dry eyes anymore. Our eyelids also become looser, and so the tears don't stay in, they can come out. You know, this is an example, I think, of where our specialties go wrong. I had a gentleman that came in, and we call it ectropion, where the lower lid pooches out, and he had such bad ectropion, and the lid margins were so exposed, they just looked so red and so painful. And he has macular degeneration, so he sees a retina specialist every 6 weeks for injections. And I said, has anybody talked to you about getting the surgery for your lids? And he said, well, you know, somebody mentioned it a long time ago, but nobody's really said anything. It's a simple procedure. And I said, well, I'm going to talk to you about it. Go get that done. You will be amazed at how much better you are going to feel when you have that done. But it's just, again, his retina specialist is just going right in, giving him the shots, and not really thinking about how uncomfortable that was. And then we also have a lot of prescription drugs. We have Restasis, we have Sustain, now Sustain, I think, so there's just a lot that's available. You can get punctal plugs to keep the tears in the eye, so don't suffer. You know, if you're putting artificial tears in your eyes more than a couple of times a day, just go in and see what can be done to make things better. The prescription drops are not just artificial tears, they actually change the tear production. And so they make your tears healthier tears that stay on the surface a little bit longer. Well, let's now start looking. So those are the normal things. You know, we talked about all the normal things, but now let's talk about real vision loss and what some of the risk factors are. Genetics or family history, accidents, injury, poisoning, aging, high blood pressure, medical conditions such as diabetes, hypertension, some medications, substance abuse like alcohol, tobacco, and illegal drugs. So there's things on here we cannot change. We can't change our genetics or our family history. But if we do know that we have glaucoma in our family, then, or macular degeneration in our family, there are things that we should be doing. If we know we have diabetes in our family, there are things that we should be doing. So I think that, yes, we can't change our genetics, but we can change our family history to some extent by changing our behavior. Accidents, injury, poisoning, some of that we can help, some of it we cannot. Aging, in spite of all the plastic surgery, in spite of all the creams, in spite of everything they're telling us, we are going to get old, if we are lucky. You know, and that's one of the things that just really upsets me. many of you have picked up some of these magazines that are supposed to be health magazines, and the first 20 pages are all about plastic surgery? And, you know, making us look better. And that really ticks me off, because that does nothing to do, we're going to get old. You know, if we're fortunate, we are going to get old. And all the plastic surgery in the world is not going to change that. And so the thing to do is to make yourself healthy on the inside so you can still do the things you want to do. And that's what keeps you from getting old, is keeping your mind going. And that has nothing to do with plastic surgery. Well, for now, who knows what they're going to do. Pretty soon we'll get injections in our brain to keep us young, supposedly, I guess. So high blood pressure, diabetes, some medications, and then I have to throw in the tobacco thing. You know, we do know that cigarette smoking affects your vision. We know that. People who smoke are more likely to get cataracts. It's related to macular degeneration. If you have diabetes and hypertension and you smoke, you're going to get macular degeneration. Let's just say that right now. And so when I have a patient that walks in my room, like I did yesterday, that smelled so bad of cigarette smoke, and he already has an eye disease in his early 40s, you just want to whop him upside the head with a V8 thing, you know? Like, what are you doing? And, you know, so we had a little chat. Whether he's going to change, I don't know, but you know, there are things we can change. So let's just do what we can. So the big four are macular degeneration, cataracts, glaucoma, and diabetic retinopathy. And cataracts, glaucoma, and diabetic retinopathy are considered diabetic eye disease because people with diabetes get those more. So we are in San Antonio, so this is important to us because we do have so much diabetes in our city. Macular degeneration is the leading cause of blindness and vision impaired people older than the age of 60 in America. And the macula is the part of the eye that gives us our detailed vision. Hello, we have a ghost. It gives us our detailed vision. And so it's the center part of the macula, center part of the retina, and it allows us to see detail. It has the highest concentration of photoreceptors in the eye. So it's like our high resolution TV. It has all our little pixels, and that's where we can see good detail. Unfortunately, for some reason, it starts to get damaged as we get older, so that by the time we are in our 80s, 1 in 10 Caucasians will have macular degeneration. So the interesting thing about it is that even though people over 80 only make up about 10% of the let's see, they're 1/3 of all cases of legal blindness, and so macular degeneration is just really important for us. 1.6 million Americans over 60 have advanced macular degeneration. So at a conference like this, it makes good sense that we would talk about this. So this is a normal eye. I'm going to get over here. And this is the macula. It's an avascular zone where we have no vessels, and that's where we have a nice clear picture. So this is a nice healthy eye that I don't get to see a whole lot of. And this is macular degeneration. So you can see this little area right there where the retina has been damaged. And when that happens, you get this big scar, blind spot right in the center of your vision. So what it's like, if you would put your hand here and you look around, if you try and look at somebody looking straight ahead, they're gone, and you have to kind of turn your head to see that person. So you have a blind spot right in the center of your vision. What happens is that you're not able to recognize faces and you can't read, so people don't want to go out anymore. They have difficulty with distance and depth, so they can't get around safely, leads to falls. They lose color and contrast, so they can't do a lot of their leisure and household tasks. So this is a very isolated disease. They can still get around well, they look normal, they look like they don't have a vision problem, and so they feel like that people will, here's what they'll tell me: I don't want to go to the mall anymore because if somebody says hi, I can't tell who they are. And so they really become very, very, very isolated. Cataract is the leading cause of blindness in the world, but it shouldn't be significant in the United States, but it is responsible for about half of mild vision impairment. We don't remove cataracts as early as we used to because the reimbursement is not what it used to be. And so they really will put off doing cataract surgery until it's adversely affecting vision. People with diabetes are twice as likely to develop cataracts, and they develop them at an earlier age. And as early as in their 20s, they can get cataracts. The problem with cataract, we talked a little bit about, you have trouble with glare and contrast and reduced acuity. So this is a picture of a cataract. That's a dilated eye, and you can see no light is getting through that pupil at all. This is a young person that's had a traumatic cataract. So this is a dilated pupil, and that's how it should look, and that cloudiness is the cataract. And what you get is just this overall reduced visual acuity. Where cataract is a problem for my patients is if they have already lost vision in one eye. And did you have a question, Victor? Sure, go right ahead.
Sunlight, ophthalmologist told me that the sunglasses is really good to help reduce cataracts.
Absolutely. Ultraviolet, here's how you can think about a cataract. You know, if you leave a newspaper out, just over a couple of days, it kind of turns yellowish. Well, that's caused by sunlight. That happens to the lens inside the eye. And so by wearing glasses, and almost all glasses nowadays, even clear glasses, have ultraviolet protection. So it's pretty much required that we wear ultraviolet protection. And then that will, not only cataracts, but, and we're not even going to talk about all the things that ultraviolet does, but we think that it can also cause macular degeneration. And here's an interesting thing. To see somebody over the age of 70 that doesn't have a cataract or hasn't had cataract surgery is really rare. But a lot, I shouldn't say a lot, but a fair percentage of my macular degeneration patients do not have cataracts and have not had cataract surgery. And what I think is, for some reason in those patients, the lens inside the eye did not absorb that ultraviolet protection, and it went straight through and hit their macula, and bam, they have macular degeneration. So it is protective that the lens inside the eye absorbs that UV damage because it protects the retina. And even the lens that they put inside the eye after cataract surgery, it has ultraviolet protection too. But I think in Texas, you know, when you see little kids wearing sunglasses, they really should be. I mean, they should be wearing sunglasses, especially when you consider that because the ozone layer has been depleted, what we're getting now is much more potent than what we were getting when I was a kid. So I think it is very important to wear sunglasses. So as far as cataracts are concerned, I think that when I have patients that have lost vision in one eye, and they're hesitant to do cataract surgery on the other eye, because there's always a risk. Every surgery carries a risk. And so what we will do is we will look at the risk versus the benefit. I had a patient yesterday that's right in that boat. He's got very, very high myopia, so he's got a very thin macula to begin with. One of the risks of cataract surgery is macular edema. They really don't want to do cataract on that eye, and so for him, you look at risks versus benefits. When it gets to the point where he's not able to do what he needs to be able to do, then they're going to do cataract surgery because the risk is gone. There is no more risk. He's not able to do what he needs to do. And so I end up seeing a lot of patients with cataracts that we're just trying to keep them going. And oftentimes, by using the tinted lenses, and it shifts their prescription in the nearsighted direction, and we just keep giving them stronger and stronger glasses, we can keep them going for a couple of years. The other time we don't want to do cataract surgery is in some of our patients that have health issues. You know, if they have brittle diabetes, their hypertension is sky high. No surgeon wants to take that person to the table, even if we're doing a local. And so, and cataract surgery is under local anesthesia a lot of times. So I see my fair share of cataracts just because the patients are at risk. Now, glaucoma, we have 2.2 million diagnosed cases and just as many that are undiagnosed. It's a progressive optic neuropathy that has a particular pattern of visual field loss. We don't know as much about glaucoma as we wish we did. People with diabetes are twice as likely to develop glaucoma. It's the leading cause of blindness among African Americans, and is becoming huge in the Hispanic population as well, which may be tied in with diabetes. It causes difficulty with reading because of visual field constriction and difficulty with getting around. The sad thing about glaucoma is that people won't notice it. It's such a gradual change in the peripheral vision that by the time they notice it, it's a nerve. You can't fix nerve. And so once that damage is gone, the damage is gone. So again, family history of glaucoma, you need to have your eyes checked every year. And you can't just have the pressure checked anymore. You have to look at the intraocular pressure. You have to get a good stereoscopic view of the optic nerve. You have to do a visual field test. And you also have have to do a corneal thickness test, because we now know that the pressure that we measure is dependent on the thickness of the cornea. And there's a new type of piece of equipment that gives us a real detailed view of the optic nerve called an optical coherence tomographer, and that needs to be done. So it's not as simple as going in and getting your pressure checked. When I worked at the Texas Diabetes Institute, I had one day where I saw most of my glaucoma patients. I hated that day. I would go home with a headache because it's not easy to diagnose. It really is not. It's not black and white. And yes?
And does THC or cannabis really help it?
The cameras?
No, does cannabis or THC, does marijuana really help glaucoma?
Well, you know, it does, but other things help better.
Okay.
You know, and they make you feel better about your glaucoma.
There you go.
You know? But, so there are other ways that we can, so it does lower pressure, but we have other ways of lowering pressure that lower it better. But again, you know, to each his own. So, and actually, you know, I have a patient that has RP, and she has read somewhere that it also is supposed to help with people that have retinitis pigmentosa. So, you know, who knows what can happen. But again, there are tablets, so you don't necessarily have to smoke it. So there are ways to get it prescribed. But I think that we just joke about it a lot in the eye field, as you can imagine. It's a big joke. Now, as far as glaucoma, what ends up happening, oops, I went the wrong way, is that this is the optic nerve, and it starts to get destroyed from the outside in, and that the temporal nerve fibers are on the edge, so that's why you lose your peripheral vision first. And again, it just leads to this tunnel vision. Now, Doctor, yes?
All those tests you made, you said your frustration on the glaucoma gate, are they done routinely at a certain age?
No.
Because I mean, I've talked to a lot of people who they be going to the ophthalmologist annually, and all of a sudden, I got this severe glaucoma and I'm on the verge of blindness.
Right.
What's going?
It's not routinely done. And I think that that's the scary part, is that, I'll tell you what is routinely done. Pressures, corneal thickness, dilating the eyes. Those things have to be done. Because you can't rely on the pressure if you don't know the corneal thickness.
So those three things should catch you.
Those three things have to be done. And I think that what ends up happening, and I see them all the time too, and believe me, it's hard for me when I get a patient that has been seeing the same eye doctor for a long time, and now suddenly they've already lost vision from glaucoma, because that should never happen. Because you see it happening to the optic nerve. You know, in fact, I just kind of skimmed by that slide, but that's this one. And this just shows the progression. You know, a small cup, and it just gets bigger and bigger and bigger with time. Now, when you get in this area, that can be normal for one person, or it can be glaucoma. You don't know. If you're seeing that person for the first time, you better figure it out. So that's the person that you do the optical coherence tomography, that you do the pressures, you do all the stuff, because you don't know if that's normal for that person or not. You may even have that patient come back in on another day and say, let's just check your pressure another day, because it can really vary. But if you've been, if you've been following someone for years, there's no reason. So it's hard, you know, it's hard. Yes?
So, can you delineate, should it be an ophthalmologist versus an optometrist?
It should be a glaucoma. Optometrists can be certified in glaucoma. I'm a glaucoma certified optometrist, but they all are not. So I think it can be an ophthalmologist or a glaucoma certified optometrist. If it's not a glaucoma certified optometrist, then no. And they will have TG. I had to think of my license. What does my license say? You'll have your numbers, and then it will have a T at the end, which stands for therapeutic, or it will have a T and a G for therapeutic glaucoma. And so you have to look for the therapeutic glaucoma. So I think diabetic retinopathy is the big one for us, because more than 5.3 people over the age of 18 have diabetic retinopathy, and 1 in every 12 people with diabetes over the age of 40 has vision-threatening diabetes. And diabetic retinopathy occurs because the retinal blood vessels become blocked and they leak. And if you look and see these little areas here, those are those areas that had leakage in the past, and that's what areas where they're leaking now. And what you see is these blind spots. And so they have like a Swiss cheese effect. So what happens with, is that if this person doesn't have, if this is their phobia right there, that person could have 20/20 vision, never know they've got a problem. And yet they are really close to this horrible, damaging vision, because once the retina's not getting enough oxygen, it will start to develop these little faint blood vessels. And those little faint blood vessels are very fragile, and they will break, and when they break, you get this. You get this huge hemorrhage in the eye. So someone can go from 20/20 vision to not being able to see anything overnight. Overnight. But it didn't happen overnight. It just, they didn't know they had it. And so people with diabetes, when I worked at the diabetic eye clinic, we would see people every day coming in for the first time for an eye exam with vision where they already had to have laser. And so they didn't even know they had diabetes. So these are the kind of things that we have to look at with our patients, really stress preventative care. So what happens with diabetes? They can't read, they can't recognize faces, they have increased sensitivity to glare, difficulty with light-dark adaptation, difficulty with distance and depth, loss of color and contrast, fluctuating vision, and the big one, difficulty with diabetes self-care. So they can't draw their insulin, they can't monitor their blood sugar, and so that's something that we need. They can't manage their medications. We saw a patient yesterday that lives all by himself, and his vision was so poor, and he had diabetes, and I said, how are you managing your medication? Well, he has somebody that comes once a day that kind of puts it in the little bottles for him, but I'm telling you, I wonder how much of that medication lands on the floor. Melvin, who does home visits, can tell you a lot of that medication ends up on the floor. And then I said, how do you eat? Who prepares your meals? Well, he was as skinny as a rail. I am sure he's not eating. And so, you know, that's a health-threatening situation. And that's where Melvin comes in. And she will talk about that. So some other causes of vision impairment: congenital ocular disease, retinal dystrophies, injury to the brain and eye, and stroke. So what is low vision? Any chronic visual deficit that impairs everyday function and is not correctable by eyeglasses, contact lenses, or surgical or medical intervention. So, you know, this is not, you know, people will say, well, you know, without my glasses, I'm legally blind. Well, that's a misnomer, because legally blind means with your glasses. So it's with correction, you still can't see well enough to do what you need to do. So according to Webster, rehabilitate means to restore or bring to a condition of useful activity or health. And so that's the process we use to train someone to be able to perform tasks in spite of a loss of physical function. It's goal-driven. The patient tells you, this is what I want to be able to do, and it does require a multidisciplinary approach. So in low vision, the physical function that has been lost or compromised is vision. And our goal is to teach the person that has vision loss how to perform their daily activities with reduced visual function. So the first step is a low vision evaluation. I mean, we have to know what their visual function is. That makes sense. And the purpose is to determine what vision the patient has that they can use to perform the tasks that they need to be able to perform. So it really is looking at what vision is left. Most eye exams are geared, especially ophthalmology. I was going to try and say ophthalmological, but we'll just say ophthalmology exams. Most of those exams are just geared at how much vision has been lost. And we look at how much vision they have left. And it's really critical information for everybody. Say you have a stroke patient, or you have a diabetes patient, that you're trying to get them to take better care of manage their own diabetes. Don't you think it's important that you know what that person can see? I mean, those things are critical information for everybody that's involved with the health of this patient. So the ultimate goal of most people is to enjoy a high quality of life through mutually satisfying interpersonal relationships and meaningful contributions in a manner that allows them to value themselves and to be valued by others, family members, friends, and neighbors, and society as a whole. Wouldn't you all say that's your goal for yourself? I mean, that's what we all want. But when somebody loses their vision, they immediately feel like they're not valuable, they feel like they're a burden. And that's where we come in, is to try and get them to feel important again. So my job is really to figure out what's going on, what are their visual functions like. I usually serve as the coordinator of the low vision team, and then I prescribe the optical devices. Oh, I mean, that was one change I needed to make. Melba does the non-optical, and she does a lot of the optical stuff now too. It's a little different from a regular exam. It takes about an hour. We do an extensive history, trying to figure out what the patient wants to be able to do. We do the functional tests, And then we discuss the rehab plan and determine what other resources are going to be necessary. For instance, my gentleman that I saw yesterday, Meals on Wheels. He needs Meals on Wheels. He needs somebody coming so that he's at least getting a good meal. He probably needs home health. You know, we see a lot of patients that are on home health that probably don't need it, but this is a gentleman that really needs it. So those are the kind of things. Do they need to be referred to an agency? Do they qualify for services through the VA? So that's kind of what Melva and I do working together as a team. So the components are distance and near vision. We use large targets. We use numbers and letters or symbols, whatever's going to be easiest for the patient. We use single letter and text. One of the things I think that's important is we can get visual acuities even on somebody that's nonverbal or that has aphasia. So even if they're not able to speak well because they've had a stroke or brain injury, we can still figure out what their vision is. We do retinoscopy, which is just an objective way of figuring out what their prescription may be. So again, in a nonverbal patient, I can use my autorefractor or I can use my retinoscope and figure out what their prescription should be. So we can even get glasses for somebody that's nonverbal. Of course, the first step is to determine if the visual acuity can be improved with lenses. Most ophthalmologists don't have staff that can do that very well. So we see a lot of patients that have been followed for years and they haven't changed their glasses in years, and we can make an improvement. The refraction is the which is better 1 or 2 part. Most of you who've had that done have probably had it done behind this piece of equipment here, but for most of our patients we use a trial frame because it's just a little bit easier for the patient. We can use bigger increments of change. They can hold their head in whatever direction they need to hold it. You know, it's funny, you learn something new every day. You can certainly teach an old dog new tricks. I do see a lot of deaf, vision impaired patients, and I had one yesterday. Most of them will have fairly good central vision because what's affiliated with them is retinitis pigmentosa, which affects their peripheral vision. I almost always do them behind the phoropter, and I had this process, and I finally had one yesterday. I did it with a trial frame. Oh my gosh, how much easier it was to do the refraction behind the trial frame. And I thought, oh my gosh, all these years, and I just figured that out. So you learn something new, but the trial frame is great, and it's great on our older patients. They get really uncomfortable when you put that thing in front of their face. You put a trial frame on and you just put a lens better this way or that way. It's just so much easier for them. It's really important because we have to know best corrected. We need to know that because that's what allows them to qualify for disability. We need to know that because it's what allows them to qualify for services, and we need to know that because it determines what power we're going to need in the devices they use. And frankly, I'm sick and tired of ophthalmologists doing a bad job and qualifying someone for SSI, and they're not legally blind because it sure makes me look horrible when I have to tell a patient, oh, guess what, you're not legally blind. Don't you think that person would be happy? Oh no. Oh no. Sometimes I have fear for my life because they're really angry. I had one yesterday. I got so angry that I finally said, do you want to just leave? Or do you want to drive? Which do you want? Because you can't be legally blind and drive. And I had a resident, so I always hate when I get a little snippy with a patient with a resident. But, you know, she said, you know, you had no choice because he was just getting so angry. But he should be angry at the guy that called him legally blind in the first place when he really wasn't. So I just said, you know, here I get penalized for doing a good job. I get you to see well so you're not legally blind and you're rad.
Yeah.
One of the hazards of the job. So then we do peripheral field testing. I use a tangent screen, which is really, really easy. A lot of patients have hemianopsia, but it does give me an idea if they can get around safely or not, and it's helpful for family members to see what's going on. We also test central vision because with our macular degeneration patients, that's very, very important. Do they have a blind spot in their central vision? The one that's really, oh, I don't know how that happened. That's weird. Well, that's okay. I've got double vision as well. 2 tests in 1. Now, can you fuse that? We'll put on 3D glasses and see if this works. But what this does is this I use a little laser and I keep shining it and they tell me whether they can see it or not. This patient has a big blind spot here, and this patient, if that showed up well, would have have a green type blind spot, which we see a lot of. We have a new piece of equipment that we can do called microperimetry, much more sophisticated way to map macular scotomas. What I like about it is it lets me get the very small ones that I won't pick up on my laser pointer, and those are the ones that scratch your heads. You know, somebody comes in, they're reading 20/40, you can't understand why they're still having problems. You do the microperimetry, and they have a teeny tiny little blind spot. It also allows us to monitor progression better than visual acuity, because they may come in and still read the same line, but have a lot of functional difficulty. And if I do the microperimetry and their blind spot is either bigger or closer to the center of their vision, then that explains why they're having trouble. And this is what it looks like. We actually take a picture of the retina itself, and then we do the perimetry right on the retina, and this red is where that person's blind spot is. And then the green, so the lights are low intensity to very, very bright intensity. Where the green is, that was a very low intensity light, and so they could see it very well. And this was a very bright light that they could not see at all. And when you look at the retina, you can see exactly, it corresponds exactly where the damage is with the retina. Where I have also found this to be helpful is in a patient I saw recently. She didn't have a blind spot, but what she did show was that right in the center, it had to be a pretty high intensity light. So she had reduced sensitivity in the center. Oh, and this is the one that we do, color and contrast, and this is my test where I have the darker at the top and it just gets lighter at the bottom, and I just use the tinted lenses to see if it helps, and then I do the color test with the colors that look like either poker chips or look like eyeshadow. I had one little boy that I lined up, and before I got a chance to number him, he raked them in, and his dad was like so embarrassed, oh my gosh, he watches us play poker. It was very, very cute. So color vision is important for activities of daily living, like we talked about, and so we kind of really talked about that a little bit. I do look briefly at the internal and external ocular health, but that's not my hat. You know, if I see something wrong, I'm going to refer. I do look at some optical devices, but frankly, what I want to know is just where's the patient at emotionally, just really talking to them about what they want to do. Do they have the emotional strength to do what they need to do? Do we need to refer them to counseling? We refer them to support groups. We talk about everything they need to do, and then what devices do we need to get them to do that? I almost always refer my patients to Mel, the occupational therapist. She's going to look at the non-optical devices and some of the optical devices as well, and then we'll address all of the goals that we talked about, and then work on the ones that are the most easily attained, which is usually reading, and discuss those that may not be reasonable goals like driving. And that's one of the things that we've learned, is it's not just good enough for us to just talk about what we can do. We do have to talk about what's not going to be possible anymore. So the low vision evaluation is one of the necessary first steps, and then we can make all the referrals. So I kind of work like a rehab doc and just, okay, I send the letters to everybody that needs to help our patients. And it's a big team that we use. The patient, their family members, the social worker, psychologist, the allied health people, a big team just as in any other rehab team. We use a lot of the same people with our patients. Does anybody else have any questions about anything before we turn it over to Mel and talk about her part? Yes?
Can you talk about retinal holes? What are those?
Yes. The retina has 10 layers. And so in the, I started to think, is it one more? But no, it's the cornea. We have now recently found a new layer in the cornea, but not the retina. So there's 10 layers to the retina. And the vitreous has a real strong attachment to the retina right in the macular area. And the vitreous is like jello, and as we get older, it starts to liquefy, and it can start to pull on the retina. And when it pulls, it will pull right there in the macula, and it can pull a plug. It'll just pull a couple of the top layers of the retina right off, and that's when you have a macular hole. So we can see impending macular holes, and we do surgery now. We don't see the kind of damage that we used to see for macular holes, because for someone that's being seen regularly, they will usually pick it up, and so there's some things that they can do to get that vitreous so it's not pulling so tight.
Is that called retinal detachment as well?
Well, that is not the retinal detachment. Usually when we talk about retinal detachment, it is at the edges of the retina. But a retinal detachment, yes, you can get a retinal detachment in the center of the retina, more likely due to diabetes, because diabetes will do the same thing. It will get vitreous strands that will attach to the retina and jerk it right off. But most of the time in the macula, it's rare to get a retinal detachment in the macula unless it's due to a macular hole or due to diabetic eye disease.
What about really being very, very nearsighted? Is that also a risk factor?
Yes, and it's because people that are really, really nearsighted are usually really nearsighted because their eyeball is very long.
Yeah.
And we all have the same amount of retina. So it's like stretching a carpet. And you know, have you ever seen it? You gotta really stretch that carpet to the edges, and where's it most likely to be thin? It's most likely to be thin at the edges, and it's also most likely to be thin in the macula. And so people that are very nearsighted are much more at risk for retinal detachment. In fact, the gentleman that I had that was really upset with me about not being legally blind, the reason he was very nearsighted and he lost vision. And mind you, this was also the guy that smoked, so he was not my best patient yesterday. He had lost vision in the other eye because he got hit in the head when he was a kid. You know, somebody as a joke, teenager walked him upside the head and he had a retinal detachment and lost vision in that eye. Any other questions?
What about floaters and aging?
You know, floaters become more, the vitreous is that gel. As we get older and it liquefies, it has strands and cells. Well, now they're moving and they're kind of floating around, so you see them. You didn't notice them when they were stationary, but now they're floating around, and you do get more as we get older, and so they're very annoying. Unfortunately, there's not much we can do about them because the surgery to fix it is too risky. So there's not a whole lot we can do about them.
Well, I was told by my eye doctor that floaters, if you're having more of them, that could mean
A retinal detachment.
yeah.
And so and also a floater is different from a scotoma. So when we have a patient that comes and says, I have a black spot in my vision, the question is, does it move? Does it move when your eye moves? Is it easier to see when you're looking at the sky? Oh yeah, oh that's a floater. No, it doesn't move. Everywhere I look, there's that spot. That's a blind spot. That's not a floater, and that's different. Also, with a retinal detachment, you can get, it's a shower of floaters, or it's a big wave floater. And so it's like a curtain that kind of comes down in your vision. And so it's different than the floaters that you see. So if you see these things that kind of move around, you know, if you're really perceptive, this is a nice little trick if you close your eyes and look up towards the sun, you can actually see the little blood vessels flowing through the capillaries in your retina, because the blood vessels are on top of the photoreceptors. So, you know, a little trick. I was an odd child. I guess odd children grow up to be odd adults, probably, right? Any other questions? Yes?
People with migraine headaches, sometimes they complain about the loss of vision.
Yes.
What is that?
Well, you know, they think that may be because they're actually getting blood flow restriction in a part of the brain. Because people who have persistent migraines will actually get some visual field loss over time. So there is something going on in the brain. And we call that, they can either get, they can get, some people will get tunnel vision, some people will get the little lights. They all kind of can be different. We call it the visual aura that precedes a migraine headache. The good thing about it is, if you have prescription medication for your migraines, you take it. You know, the minute you see that, you can stave off the headache. But the bad part is, you want to figure out if you can try and keep from getting that, because over time they will get peripheral vision loss. So that's why we know it's something that has to do with the brain. Any other questions? All right. Can Melvin just go straight through? Can I just
You want it? Sure, that's perfect.
You know, I didn't even really introduce myself. I was supposed to. Well, I'll introduce myself now. I think it said on my chart that on my slide, the director of the Lyons Low Vision Center, and my chart. Could you tell we're doing Epic? I mean, all we talk about now is we're going to electronic medical records, and it's very tiring right now. Melvin and I have been working together, believe it or not, 10 years. In August, it'll be 10 years we've been working together. She's an occupational therapist. Her background has been with working with a lot of neuro patients, so that has been just so helpful for me in our clinic. One of the things that's been very, very helpful for me is that you know, optometrists and ophthalmologists, we tend to look at people just from here to there, you know, we don't really pay much attention from here on down. And so it's very helpful to have somebody like Melville working with me that has more experience in identifying if somebody's got, you know, if they may have arthritis in their shoulder, they can't hold a magnifier. And just when you think about what we talked about earlier, what rehabilitation is all about, it's about finding strategies. You know, getting people to be able to do what they need to be able to do, and that's not my best area. That's an occupational therapist area. And so Melva joined us, we worked together now all these years and are a pretty good team and like some old married couple pretty much. So I'm gonna let her come up here and talk about what she does.